pneumonia was referred to our hospital by his local doctor. 1 week before being referred to our hospital, he visited his local doctor for further evaluation after being suspected of left ventricular hypertrophy during a regular checkup. During his visit to his local doctor, it was found that his appetite had decreased for 1 to 2 months, and he could consume less than 1 meal per day, and his body weight had decreased by more than 10%. Finally, we suspected chronic heart failure. He was referred to our hospital. And he had a history of hypertension, Alzheimer's disease, and interstitial pneumonia, but well controlled. The steroids had been gradually tapered off and were completely discontinued 3 months ago. His medications included periphenidone for interstitial pneumonia, azucarthan for hypertension, and rivastigmine for Alzheimer's disease. No allergies, and he had a past smoker who had smoked 20 cigarettes per day for 30 years.
Very good. Is this a good place to stop, Yuji?
Yes.
Awesome. And Himon, do you have any questions? You said that for the medications. Oh, we have it all right there. Perfect. This is a very interesting start to the case. And I say interesting because there's two diagnoses that I'm considering that are usually incompatible with each other. And what do I mean by that? When someone has new suspected heart failure, we expect them to retain water, yes? And when you retain fluid, what happens to the weight? It should go up. So now we have someone who seems to potentially be in a decompensated heart failure, but with weight loss. So those two should make you pause for a second and ask the question, what can link them together? Note that patients who have heart failure over time can develop cardiac cachexia. It's just the increase in metabolic rate associated with end-stage heart disease, end-stage lung disease, end-stage liver disease, and you just start eating away your tissue as those organs eventually, become fibrotic. So what I'll do here is I'll first step back and say what leads to weight loss, and then we'll talk a little bit about the heart and see how we can overlap it with the weight loss, while tracking the fact that he has this unknown interstitial pneumonia diagnosis that was briefly treated with steroids and now seems to be on some antifibrotic agent. So with weight loss, the easy way to think about it is ask the question, is it inflammatory, like related to underlying inflammation or not? Now, that's like the most simple approach. And when we think of inflammation, infection, cancer, autoimmune processes, the reason to think about that as a possibility before moving on to the next category is the new suspicion for heart failure. Because if you tell me someone has a new diagnosis of heart failure with weight loss, all of a sudden I'm thinking about inflammatory etiologies, meaning something that is causing that heart to be inflamed, whether it's the myocardium, the endocardium, or the pericardium. But there's another way we can link the two together too. For example, if someone has thyrotoxicosis or thyroid disorder, and so their metabolic rate is up, they're losing weight, and they might be in a decompensated state because of their excess thyroid hormone. Beyond inflammatory causes of weight loss, you can just picture the route of liquid or food going down the mouth. It requires you to have access to food. So people who don't have access to food may have weight loss. That doesn't seem to be the issue here. You have to have the strength to pick up the food and move it to your mouth, chew it, swallow it. But he's not really complaining of weakness, dysphagia. So it's unlikely to be relevant here. Then once the food goes down the esophagus into the intestine, it has to be absorbed. So malabsorption from pancreatic insufficiency, celiac disease, etc. You don't need to have diarrhea to have malabsorption, but there's no mention of that. Usually when you have a hypermetabolic state from thyrotoxicosis, diabetes, or pheochromocytoma, usually the appetite is not changed, meaning that they still eat the same amount, but because of their high metabolic rate, they end up losing weight. I don't think that's the case here. But where are we then? Where we are is trying to understand why this patient lost weight. It's probably not food insecurity. It's probably not depression. It's unlikely related to the medication. So I'm not sure what the side effects of the antifibrotic agent are. And we have to entertain, can it be something inflammatory because of the new onset heart failure? Now, heart failure in someone who's 86 years old is probably part of the metabolic syndrome, meaning prioritizing HFpEF over HFrEF, because when you have hypertension, when you have obesity, the heart is over time, it's pumping over this high pressure and it becomes thickened. And so HFpEF ends up being another manifestation of the metabolic syndrome. But it's just a bit suspicious why that would happen now at the age of 86. And you start wondering, is that disease that's affecting the lung also affecting the heart? Meaning whatever is infiltrating that interstitium, or was a CT scan slam dunk for idiopathic pulmonary fibrosis? Remember, that name is idiopathic, so you do get some characteristic imaging findings that can be very suggestive, but you have to consider other possibilities. So I think, Yuji, I'm still not sure of the problem I'm solving. I'm just sharing some preliminary thoughts. But ultimately, what I'm going to do with the physical exam is really look at the JVP, see if there's lower extremity, see if I actually have definitive heart failure. And if I do, then I'll share, the framework for that, but keeping in mind the patient's weight loss. And I'll also be looking up the side effects of these medications that you provided, particularly the antifibrotic, and maybe the audience can help me out with that. All right, Yuji.
Okay. So can I proceed with the presentation?
Please.
Okay. So his vitals were good. Temperature was 99.1, and heart rate was 79 in sinus rhythm, and blood pressure was 125/75. Pulse ox was 96% on ambient air. The general condition, he looked quite emaciated and appeared fatigued with a sluggish reaction. HEENT, conjunctival pallor was noted, neck, supple neck, no goiter, no lymphadenopathy, no JVD. Cardiovascular showed no murmur, no peripheral edema. Pulmonary showed mild fine crackles in the bilateral lower lung fields. Abdominal bowel sounds present, soft and non-tender. And laboratory tests showed white blood cell 4,700, neutrophils 55%, lymphocytes 31%, monocytes 8.1%, eosinophils 3.7%, basophils 0.9%, and hemoglobin 8.4, and MCV 78, and RDW 46, platelets 166,000, sodium 140, and potassium 4.4, chloride 111, BUN 16, creatinine 1.08, AST 21, ALT 12, and albumin 2.7, and CLP 4.65. It is actually elevated in Japanese criterion. BNP 72.4. And images, chest X-ray showed thoracic cost thoracic ratio is 60%, and cost phrenic angle was rounded on left side, and ground glass opacities in lower lung fields were noted. And ECG showed sinus rhythm moderate ST segment depression in leads V4 to V6. And echocardiogram showed ejection fraction was 67%, no asthenia, but surprisingly, left ventricular hypertrophy noted by the previous doctor was not evident. And left atrial dilation was noted, and E bar E prime was 12. It was actually higher than normal. So diastolic dysfunction couldn't be ruled out.
Yuji, this was great. Luckily, I have my co-host who's back and eating. Robbie, do you need any updates before you start analyzing, or you feel pretty up to date?
I'm officially Reza's greatest fan, purely voluntarily out of my own volition. No, I was lucky enough to hear your poetry, Prof. Reza, and maybe I can just reflect on the exam and pass the rest to you, and then we can dance thereafter. And I think what the exam did for me, honestly, was just to, as we tried to sort of tackle the two problems, heart failure and weight loss, the exam in isolation had me underweigh the heart failure and prioritize the weight loss. And it became so much more so looking at this cachectic person and seeing how much weight they've lost, and seeing also that they likely had anemia from the conjunctival pallor, and moving a little bit away from the heart failure. So with that lack of JVP and the normal O2 stat. So I think it's really interesting when we talk about patients with heart failure and weight loss. Most of the patients that I'm imagining in my mind have really bad heart failure and have some weight loss associated with it. And so the examples that of hyperthyroidism, so on and so forth, this seems to be interesting where the weight loss is so prominent and so stark, and the heart failure is subtle enough that it is not very prominent on the exam. And so I'm just intrigued by that scenario, and I'm really curious where it will take us. But that's what I got out of the exam. What did your mind do with the other data?
That's not enough, Robbie. We need more Robbie. Keep going.
All right, I'll do the labs too, okay? And then you can take on the imaging. Yeah, so labs are, I think, just really reinforce what the exam said, and then I think Prof. Raz will counter argue why the heart failure is prominent. Because if you look at the labs, the BNP is normal; it's less than 100. The CRP is high, although not impressively high, and the albumin is low, suggesting that this patient is in fact losing a lot of weight. Before we ascribe low albumin to nutritional loss, we have to remember that it's very, very unusual for low intake to cause low albumin in isolation. So the checklist of hypoalbuminemia is to make sure the liver is okay, which it is. The kidney is okay, which it might be. The creatinine isn't very low, but we always have to make sure the patient doesn't have a protein wasting process in their kidney. And so the albumin here is not from liver issues, is probably not from kidney issues, is probably related to the weight loss, but cannot be ascribed to lack of nutritional intake. So the question I think the labs leave you with is, does the low MCV help in any way, shape, or form? Does that help make progress on the weight loss itself? And if this MCV is new, which it probably is, then we're down to it being of iron deficiency or anemia of chronic inflammation. And at first glance, the patient's CRP is elevated, so I think it's fair to say the patient probably has some anemia of chronic inflammation. But the CRP isn't high enough, nor is the presence of anemia of chronic disease completely eliminating the possibility of iron deficiency. So I'm struggling with the weight loss in terms of where it lives, but I think iron labs would be very, very helpful. A UA to make sure there isn't any proteinuria are the dimensions I'm left with. But if you look at the labs, again, they all are helping us understand the weight loss, less emphasis on the heart. Prof. Rez?
I think I think that's poetry, man. And I was just thinking about our transcriptions on our Castos app, where you're always calling me professor, and I'm calling you Robbie. Okay, so this is really interesting, UG, because I think there's such an important teaching point that I actually didn't understand until probably when I started as faculty. And that is heart failure is a clinical diagnosis, meaning there is no labs, echo, etc., that can clinch it. Meaning you can have a totally normal echo and have heart failure. You can have a mildly abnormal echo and not have heart failure. So I think it's a very important teaching point that heart failure is a clinical diagnosis. It seems like in this patient, they thought based on the nuclear scan that the patient had heart failure and some hypertrophy. But here, like our exam does not show any evidence. The JVP is normal. There's no peripheral edema. And so, yeah, and the EF isn't 10%. Sometimes you'll get tricked where the JVP is so high you won't be able to detect, and the EF is 10%. Then you definitely have a diagnosis of heart failure. The EKG, whenever you see ST segment depressions in the anterior leads, this is the anterolateral leads, V1, V4 through V6. But especially in the anterior leads, you have to do posterior EKG. You're going to miss a posterior STEMI, because I missed it as a second-year resident, unless, actually I didn't miss it. I missed the possibility of it when the cardiology attending taught me this trick, but the patient did not have a posterior STEMI. And the way you can do this is you can take the EKG and just flip it upside down like you're looking at an X-ray in the olden days, and you'll see if it has that morphology of concerning ST segment elevation. So the morphology does matter. Here we're in the anterolateral leads. When we have ST segment depression, you should think about something that's causing ischemia to the heart. You really should. And it could be chronic, like Robbie, our case that we recently had of that gentleman, where a cabbage resolved the ischemic changes, or it can be acute. And I learned that there's no way to really distinguish the two besides just trying to change what that cause of demand might be. Here, we have anemia, so knowing the prior hemoglobin would be helpful. But even with the hemoglobin of 8.4, you don't really expect the myocardium to have underlying ischemia. So I noted those ST segment depressions, they're abnormal. I'm looking for either demand or underlying coronary disease to explain that abnormality. And I know that I'll be checking, repeat EKGs to see what happens to those segments. Sometimes you can get abnormalities in the ST because you have repull abnormalities with LVH, RVH. But here, we don't really have any finding to suggest LVH. And remember, we're doing an echo in a cachectic person. So there's no fat tissue that's obstructing the view of the echocardiogram. So we would have really good views, I would imagine, of the heart. What to make of this left atrial dilation? Usually when the left atrium is dilated, I automatically look and see, does the patient have atrial fibrillation? And remember, AFib is not a disorder that's always present. People go into and out of AFib. That's why it's so hard to sometimes capture, and why we always, once we capture it even once, we calculate the CHA2-VAS and keep patients on anticoagulation indefinitely because of the paroxysmal episodes that are associated with increased risk of stroke. But other causes of left atrial dilatation would be abnormalities in the left ventricle or the mitral valve that are causing increased pressure of that left atrium. That can lead to left atrial enlargement. But Robbie, I would love to hear from you. The E to E prime, I have it somewhere in my notes what that means, and I use it for constructive for constrictive pericarditis, but I think it just means how quickly that left ventricle gets filled. And so it tells you if there's diastolic dysfunction, if the acceleration into that left ventricle is slowed down. But I don't know, the echo doesn't really do much for me, to be honest. Like there's some left atrial enlargement. I'm not chasing the heart just yet. Like my focus is just weight loss and the myriad of causes of weight loss. And I think I would prioritize inflammatory based on the anemia and the CRP. But I love the idea of adding that ferritin, maybe getting an ESR as well, because that would be helpful. But what about you? Did that echo it seems like it caught your eye or something?
Oh no, I mean, I think that like I completely agree with you. It's there, it's not normal. The EKG is not normal, but like the weight losses seem so much more stark than the amount of heart failure this person has. So I'm right there with you. I think yeah, if this person had normal weight and weight loss wasn't a problem, what problem would they be left with? Their O2 sat is normal, their JVP is normal, their respiratory rate is normal. So if we pretended that there was no weight loss component to this case, so far, the heart problem seems maybe one that is developing slowly, and maybe in 5 years the patient will have a problem, but I don't think the heart is screaming at us yet.
We're not at the heart of the matter.
Oh, Prof. Rez, you're fired today. I am, in fact, your greatest fan. Alrighty, my friend. Why don't you give us the next round of data, Yuji?
Okay. So I will show the differential diagnosis at this moment. So we suspected gastrointestinal bleeding since he had a loss of appetite and fatigues. So gastrointestinal bleeding from ulcers, polyps, or cancers we considered. Cancers like colorectal or gastric cancer. And other cancers was included in the differential, of course. And since he had a loss of appetite and fatigue, and so we taken into account for hypothyroidism and adrenal insufficiency. And additionally, he had a mild inflammation, so we suspected autoimmune disease or infectious disease such as tuberculosis. That was the differential diagnosis at this moment.
Wow, we should have you join us regularly. That was awesome. Thank you so much. And so you were thinking maybe the person is bleeding in their GI tract, maybe they have an inflammatory condition. What was the next set of information you collected?
Okay, so we proceed with the images for differential diagnosis. Okay, chest CT. Chest CT showed pericardial effusion and thickening of the pericardium. And abdominal CT, there was no obvious mass lesions. And EGD, we proceed with EGD for gastrointestinal bleeding and for neoplastic lesion, but there was no obvious abnormalities. So it was likely to rule out gastrointestinal causes, malignancies, infectious disease such as tuberculosis. So considering endocrine and autoimmune diseases, we proceed with further blood tests. And blood tests showed cortisol 8.8 and ACTH 105. So this means that ACTH was higher than normal, but cortisol was normal. So we suspected this is because the discontinuation of steroids. And thyroid function was normal, actually. And since he had a pericardial effusion on the CT scan, and actually complement was low, so we suspected SLE, but SLE related antibody was negative. And another immune-related immune-related antibody like Sjogren's disease or scleroderma and vasculitis were all negative. So all differential diagnosis was negative. So at that time, we reviewed the images once again. And actually, abdominal CT showed an enlarged pancreas and capsule-like structure. Can you imagine what this is?
Yeah, Yuji, this is great. A lot of great information here. And I think Robbie and I have a lot to dissect. And I think it's so interesting. Like maybe the JVP is not, it's not a perfect exam. Remember, like we're all doing our best at the physical exam. And sometimes we might not see a distended jugular venous pulse for whatever reason. But the CT findings were quite interesting, Robbie, where it showed the thickened pericardium and an effusion in the pericardium. And then we have some pancreatic pathology. It seems like some thickening or fibrosis or encapsulation of the pancreas. So I think we finally have our pivot point. Like up to this aliquot, it was weight loss, unclear cause, anemia, some inflammation. But now we are actually getting at the heart. And I think I would focus my cognitive energy on like what causes pericardial pathology and effusion. And maybe I can just start sharing that thinking and then pass the mic to you to incorporate like the pancreas and maybe to add to my thought process. I think what's so cool about constrictive pericarditis, it's like a cause of heart failure with a normal BNP, B Nancy peptide, because it's preventing the ventricle from dilating and releasing the natriuretic peptide. And here, the BNP is high, but maybe it's not as high. Though I don't know that because I don't work in Japan, but I just want to support the statement I'm making. And whenever you have thickening of the pericardium, that to me is quite specific for pericarditis or something causing inflammation or infiltration of the pericardium. No, you don't need that thickening to diagnose it, but that's a very strong clue. And so this with the effusion, now all of a sudden I'm thinking, is this an effusive, constrictive pericardial process? And we know, Robbie, for pericardial effusion, there's so many causes from elevated end-stage renal disease to you name it can cause pericardial effusion, any cause of volume overload. But those causes don't cause thickening of the pericardium. All of a sudden, you go from this very broad DDX, it's almost like optic neuropathy versus optic neuritis, as Harry Hollander would say. So here, where they say what can cause inflammation or infiltration within the pericardium, and that is also causing the effusion. So I think the pericardium is very, very telling here. And that's when you would say, I would say like the leading hypothesis worldwide should be tuberculosis. Like anywhere outside the US, TB, TB, TB. And it can be very tricky to diagnose because we're saying presumably extrapulmonary TB, though there is some lung pathology. So it would be wise to go after AFB, smear, PCR, and culture. But sometimes you ultimately need to biopsy the pericardium. But here, you might also need to strip the pericardium because of the thickening. And what you need to do actually to understand the hemodynamics is a right heart cath. That will tell you a lot about how bad the space is in the pericardium and how thickened and how much lack of flexibility that pericardium has. So for me, Robbie, I'm going to pass the mic to you. I'm thinking, is this something infectious? I would have initially just thought TB. Then I would have included lupus, but the age, the demographics makes that less likely. Malignancy, I don't like it. But then the pancreas comes in and it broadened my different just a little bit. But I'm going to pass the mic to you to talk about that.
Prof. Rez, I love that. I love the journey of the pericardial disease and your clear explanation of why the thickening changes things for you. The patients are rolling into the ER, so I will be very brief, as I know you like me to be. Um, the pancreas is usually the site of the origin of most diseases it is involved in. This is a situation where the pancreas seems to be part of a systemic disease which is not originating from it. And to convince you of that would require more time, but I'm convinced of it for now. So when analyzing a case where the pancreas is the subject of a systemic disease rather than the origin of it, there's not many conditions that are involved in that angle of pancreatic diseases. Under the infection category is TB, TB, TB. Under the autoimmune category is the lead consideration, IgG4 disease. And make note of that theory in large part due to the pancreatic imaging, but also in a little bit part to the eosinophilia that Shema and he made note of with the CBC, which it might be low-grade eosinophilia. I haven't crunched the numbers yet, but it registered with our scribes. And so that's another thing. The other big autoimmune diseases that live in the pancreas are the histiocytic diseases. We've had a case of Rosai-Dorfman, which involved the pancreas. In terms of malignancies, we're not talking about pancreatic adenocarcinoma because that originates in the pancreas, but pancreatic lymphoma, which can also cause diffuse swelling of the pancreas, much akin to IgG4 disease. So what does the pancreas do here? I don't think it changes the DDX much because all the things I just mentioned can all easily cause a pericardial effusion, a lymphoma, histiocytic diseases, IgG4 diseases, and TB. And so I think that given the ability to sample that, given the fact that the differential diagnosis is the same, you don't get to eliminate any of these conditions. I think the pancreas just allows you to prioritize TB, IgG4 disease, histiocytic disorders, and pancreatic lymphoma. I think also, Prof. Rez, to acknowledge real life. In real life, so many patients have random imaging abnormalities that are not explained and pericardial effusions that are not explained. I think the real momentum in this case is just how frail this patient is. That really gives you a suspicion that you're going to find something. And there goes me being brief out the window. So I'll pass the mic back to you, Prof. Rez, for any other thoughts you had, and then
Yeah, just look at your name that you earned with that discussion, and then
ooh,
back to
chat
you.
GPT 5.0, amazing. Well, it'll be a permanent 5.0 as the world evolves well beyond that. But thanks for I love that you're enjoying being the host today so much. All right, Eugene, mic to you.
Okay, so we suspected AIP, autoimmune pancreatitis, at that time and proceeded with further immune-related blood tests. Actually, the lab test showed that IgZ was elevated. Actually, IgZ was 3,118 and IgZ4 303, and it was actually elevated. So the diagnosis of IgG4 related disease was made.
Sorry, I'm trying to move my other screens out of the way. Yuji, this is great. I think that the elevated IgG4 disease is certainly compatible with the diagnosis of IgG4 related disease. I think there may be many other reasons why to avoid doing that. But I will acknowledge that my diagnostic space and my diagnostic opinions still have room for other things. I say that because the specificity of an elevated IgG4 level for IgG4 disease is 80%. So if all you have is an elevated IgG4 disease, there's a 20% chance that there is something else causing that. Now, that 20% is going to be lower in a patient with low-grade eosinophilia, classic pancreatic imaging. But then the major argument to be cautious is the fact that this patient has not had the assessment for the mimicker of that we talked about, namely TB. But I think if you really go back and ask yourself, wait, what about the interstitial pneumonia? And is the patient's interstitial pneumonia actually also evidence of long-standing IgG4 disease infiltrating the lung? And then I would also ask myself, wait, hold on. I know patients with IgG4 disease affecting the pancreas also tend to affect the parotid and the salivary glands. So I think, to be honest, the gold standard of IgG4 disease diagnosis is histopathology demonstrating 4 characteristic features. All 4 of them have to be present. That's how hard it is to diagnose IgG4 disease. Realistically, that may not be obtained in every single patient for many reasons, especially maybe an 86-year-old who's frail. But I think that if you make the argument that the reason you're not going to do that is because he's had a steroid responsive interstitial pneumonia, that he has pancreatic involvement, pericardial involvement, and even pericardial thickening, very, very characteristic of IgG4 disease. You might use that as a trial to give him treatment, i.e. steroids, and see if he gets better. But if I were taking care of him alone, I would have a little bit of readiness if he were not to improve and worry about the one big thing we can't miss, which is TB. So I think this is a lesson in real life about how everybody doesn't get the gold standard test for every disease. But I think one thing that people should not walk away with is that a high IgG4 level is diagnostic of IgG4 disease. Unfortunately, it's good, but it still has some holes in it. Any other thoughts or reflections you wanted to share, Prof. Rez?
I think that was beautiful. And it also emphasizes the point when you make an idiopathic diagnosis, like pulmonary fibrosis, anything idiopathic, you just got to be cautious and be open to the fact that you're dealing with something else. And here, I think Yuji and his colleagues did a terrific job of pivoting away from that and trying to explain all the abnormalities with a single hypothesis that is quite responsive to treatment. Quite responsive. These lymphoplasmacytic cells melt away with prednisone. So if this is the correct diagnosis, and maybe you can also use that as another diagnostic test, this patient should improve significantly with low dose steroids, significantly. The weight loss, pericardium, the pancreas, everything should get better. So yeah, but I would love to hear from Yuji and see what him and his colleagues did for the patient.
Okay, thank you. Yeah. As you told, the complication of this disease is very diverse, and AIP is one of the most common features of this disease, as seen in this patient. And although not common, there had also been case reports of patients with serositis, such as pericarditis. Yeah. And initial therapy typically starts with prednisone and sometimes includes an additional immunosuppressive or 4 milligram of methylprednisone, which was the dosage of the before discontinuation of the steroids for intestinal pneumonia, and along with 5 milligram of prednisone. And after restarting the steroids for 2 months, the pancreatic enlargement was no longer observed. And pericardial effusion also subsided. Additionally, his appetite had dramatically improved. In this case, the discontinuation of steroids likely revealed an underlying IgG4-related disease, which had been masked. Consequently, the loss of appetite is considered a symptom associated with autoimmune pancreatitis, we thought.
Oh my gosh, Yuji, this is so cool. I think that Yeah, I'm reflecting on so many elements of just how sneaky this case was. This patient was taking steroids for other reasons, and how you have really beyond any high level of doubt, have proven that this is IgG4 disease without a biopsy. And quite honestly, if I were taking care of the patient, I've been told over and over again, you need a biopsy, you need a biopsy. But honestly, I'm sold. You have an 86-year-old person, 86. Life expectancy on average in Japan is almost 2,000 years, but in general is not much higher than 86. But I think you have steroid responsive pancreatic and constrictive pericarditis. I'm just in awe of this case and really just humbled by how what Prof. Rez was emphasizing. This is more a weight loss condition with a little bit of heart failure. You being underwhelmed by the echo, Prof. Rez, I think ultimately is so compatible with this disease. It's mostly a systemic wasting disease with a little bit of heart. But yeah, what were your reflections, thoughts, Prof. Rez, before we pass the mic to Shayla?
No, I honestly, for me, the highlight was that last aliquot that Yuji shared, where you were like forced to try to explain, could you arrive at this DX without a biopsy? And like it was awesome to just see you say, hey, there's the pancreas, there's the lungs, there's the pericardium. It seems compatible. And the next step is to try steroids. Yuji, you guys did a terrific job for this patient. Under our care, he would have got a biopsy and a complication, and it would have been the end of his life. But for you and your colleagues, the patient responded really well to treatment. Maybe you can share any teaching points you want to make for the audience, like any one teaching point you want the people to walk away with. And then Shema, who's subbed in for teaching today, will take it over and sum up the teaching points.
Okay, as a takeaway, I would like to share what I've learned from this case. First, be aware of cognitive error, especially when patients are referred with a suspected specific condition. Bias may arise, potentially preventing an accurate diagnosis. Second, don't overlook incidental findings. Even when imaging is done for a specific purpose, carefully examine all images for potential abnormalities. And finally, disease cannot be diagnosed unless suspected. Keep the differential diagnosis as broad as possible and proceed with accurate examinations.
Usually that's
No, Prof. Rez, please.
Oh, I was just gonna say I love it. This is a really great case. And again, I think we overdo it where I practice personally, and like using your mind and the response to treatment. I'm really really impressed. And Robbie, it really reminds me of that case we were presenting in front of 500 people where we were like, is it pseudomags? And then someone with much better experience was like, dude, just treat TB. This is TB. What are you guys doing? But yeah, what are your thoughts, Robs?
Prof. Rez, I think if you can say you have a patient who has a steroid responsive pancreatic inflammation, what are you left with? And so that's really cool to see that play out, like, because people would say steroid responsive can mean any long sustained steroid responsive can mean any autoimmune disease, but sustained steroid pancreatic resolution, I think, man,
that's the level that Yuji's operating on. It's not just steroid responsive pancreas. That's like another level, man.
I think, yeah, it was so cool, Yuji, to see you guys prove that the pancreas improved with the steroids. I think that is a very cool way to see that done. Yuji, I will just ask you to please not make this the last time you join VMR. We hope you'll come back. This was awesome. Thank you so much. Really appreciate you. Maybe you can come with a less hard case next time, though. Maybe some pneumonia or UTI or something simple. Thank you very much. Alrighty, Shema. Well,
Thank you.
Thank you. Hand the mic to you, my friend.
And hello, everyone. It's inconvenient hearing me like this. I'm so sorry, but thank you so much, Yuji. In order to spare you from hearing this cracked up voice, I will summarize the teaching points. If you have a patient presenting with weight loss, think of inflammatory versus non-inflammatory causes. And in a patient with heart failure, we would usually expect weight gain and not weight loss due to fluid retention. And in a patient with heart failure and weight loss, you can think of several things like cardiac cachexia, inflammation, hypermetabolic states, low intake, and malabsorption. And we also learned that HFpEF is usually presented in older people with metabolic disease. And also always remember, if you have ST depressions in anterior leads, always obtain a posterior ECG to not miss a posterior STEMI. Then we had pericardial thickening, and this is usually a clue for pericarditis, but always think of the most leading cause worldwide, which is TB. And TB is usually notorious for causing constrictive pericarditis, but the constriction usually prevents the ventricles from dilation. That's why we usually have a normal BNP. Pericardial effusion. Usually we have several causes like volume overload, infection, autoimmune malignancy. And then in this case, we had several clues, something like hypocomplementemia. And this is something that Kirtan always mentions, like think of IgG4 related disease, cholesterol emboli, post-strep GN, lupus, cryoglobulinemic vasculitis, and MPGN. And then Rabih taught us about when the pancreas is subject of the systemic disease. You have to think of infections and think of TB, autoimmune, like IgG4 related disease. And another clue in this case was the eosinophilia. So Rabih once taught me about think of atopic stigmata in patients of IgG4. And then also think of histiocytic disease, like Rosai-Dorfman, and malignancy like pancreatic lymphoma. And we also learned a high IgG4 has a low specificity. So there's still a chance for something else going on, something like a mimicker like TB. So usually we give the diagnosis by histopathology. So we see lymphoplasma cellular infiltrates, storiform fibrosis, eosinophilic infiltrates, and this disease is usually steroid responsive. So that's everything. I'm so sorry for this voice. And yeah, if you survive this, then yeah, thank you.
Shema, that was incredible. Oh my gosh. You remind me of Michael Jordan in games. Jazz would know, one of the games against the Utah Jazz where he played with the flu and still won the NBA Finals. Amazing job. Yuji, thank you for presenting such an instructive case and really, I think, pushing us to think harder before doing tests. And GPT 5.0, you're on fire despite having a million things happening in the background. Any last comments you want to share with the group, GPT?
Okay. Thank you for listening, everyone. It is a great opportunity for me to take part in this this chance. Yeah. Again, thank you for this opportunity today.
Thank you, Yuji. Thank you, Yuki, for your help. And we hope to
Thank
see you both.
you.
Please come back soon, okay? I know it's so hard to join during Japan time, but we really hope to see you again, okay?
Thank you so much. I really appreciate everyone.
Konnichiwa.
こんにちは。
あ、ございません。